Patients Redefining the Future of Healthcare in Canada 6th Annual Summit. We're so pleased you can join us. And just wanted to remind everyone and encourage you to please share your insights, your excitement, your enthusiasm via social media. Here's some hashtags you can use so that we can trend. Go, go, go. Hashtag Patients Redefining Healthcare, or some of the others if you prefer. Want to once again acknowledge and thank our event sponsors, including Axon, our in-kind supporter, who's providing all of our technical support. Much appreciated. None of this would be possible without you. And then just to center ourselves on where we are, day one on Monday was fantastic content, echo pandemics in healthcare. Today, we are very, very excited about what is upcoming as we explore ecopandemics in Indigenous health. Tomorrow, we will move towards what do we do about all this, the way forward. And then finally, on Friday, for our patient representatives, patients, and caregivers, we will be having a more interactive action planning day. So just to briefly touch on a few themes that we were hearing coming out of the breakouts on day one. On the sort of the content side of things, we heard quite loudly from all the breakouts that we don't want to be returning to pre-pandemic healthcare systems. Like clearly, everyone knew from the patient experience that and that there was a lot of room for improvement, and the pandemic has made it clear that it wasn't working as well as it ought to be. This is the opportunity to reform. We have an implementation gap, not a knowledge or evidence gap, and that there's a real need to move from a cost focus to a value focus, and that includes investing across the continuum, including prevention, all the way to rehabilitation, palliative care, end of life, et cetera, based on outcomes by population. And this also includes integrating and coordinating care with the patient, not for the patient. That data and information needs to be accessible to patients and shared with their circle of care. That patient-defined outcomes are important for different populations, and that health inequities need to be understood and addressed proactively as part of all of this. And then on the process side, that collaboration is key, and that includes the whole ecosystem, and especially and including patient partnerships and co-design. That there is a need for local adaptation, but with a common accountability framework, ideally based on outcomes, and that framework can be applied across the local networks, that there's a need for champions across different stakeholder groups, and innovative thinking about value and how to increase system capacity. That doesn't necessarily involve more money. What can be done with what already exists if we reallocate resources wisely, increase community-based capacity, optimize professional scope, et cetera. So those were some of the themes that we heard coming out of day one from the breakouts. And then today's agenda, we're very excited about our upcoming keynotes, Dr. Veronica McKinney and Marion Crowe, with some incredible question and answer session, facilitated, moderated by Sharon Clark. And then we will be, Dana and Victoria from the Canadian Institute of Health Information will be sharing some really important information with us with, again, opportunity for question and answer. And then we will move to breakout sessions. And you don't need to do anything at that time. You will be assigned to a breakout session, and there will be a facilitator in your breakout session. Just some quick housekeeping. While we're in plenary like we are right now, please keep your lines muted and your videos off. When we move into breakout, please, by all means, unmute yourself and participate in the conversation. We are recording today's sessions, both in English and in French. And if you would like to access French interpretation, please click on the world icon at the bottom of your screen, click mute original audio, and then select French. If we hope that you will have questions, and please share them in the chat box at the bottom of your screen. Just type your question right in there as it occurs to you, and then press enter. Our moderator, Sharon, will keep an eye out for those questions, and she'll be sure to convey them at the question and answer period to the speakers. And if you have any technical difficulties at any point, don't hesitate to contact Axon Technical Support, either number 1 or 2, You'll see them in your chat function. And then a quick reminder that there will be an evaluation survey that goes out today. Please do fill it out. It really helps us improve. There will also be an event report that will be circulated to everyone who registered after the event. And now I'm more than pleased to turn the microphone over to my colleague, Sharon Clark, for our introductions. Sharon, over to you.
Thank you, Leah. Thank you very much. Good morning, everyone, and welcome to day 2. It's wonderful to be here. And today, as you know, the topic is eco-pandemics. Sorry, maybe I should have had some of that water. Is eco-pandemics and Indigenous health. And you know, the COVID pandemic to me is like a rock thrown into water. The initial ripples continue to spread across the water, followed by more ripples as it bounces back from the sides of the pool. And these waves intersect, making more ripples. So people who live in inner cities, rural and remote areas, for example, both Indigenous and non-Indigenous, are also feeling the effects of the pandemic waves. So as many have said, the COVID pandemic has uncovered inequities in our Canadian population, and we've heard that from a lot of the speakers yesterday. So Indigenous people, because of the relationship with the federal government, the Indian Act, our mutual history, and where they live, have been severely affected by the pandemic. So I encourage you, if you haven't, to learn about the issues of Indigenous health so that you can understand many of the complexities. So the speakers today, within their areas of expertise, have been working tirelessly to do their part to address these inequities. So with that, I'm honored to introduce our keynote speaker, Dr. Veronica McKinney, physician and director of Northern Medical Services, College of Medicine, University of Saskatchewan. Now, Dr. McKinney is a proud Cree Métis physician, originally from the North, and she was inspired by her great-grandmother, a midwife, and her mother to seek a career in medicine. So Dr. McKinney is not known for taking the easiest road, and many of the challenging places she has worked attest to that. She has worked in emergency care, she's worked in Northern Ontario, British Columbia, and now with Northern Health Services. Dr. McKinney has said, our ways aren't always about the medicines, it's about how you live your life. And I think there's a lot to be learned in our Western world about that. So with that, I'll pass it over to Dr. Veronica McKinney.
Hi, thank you. I'm just gonna tee up my PowerPoint here so you can actually see, and we will, hopefully that will work for you there. So thank you very much. Tawao, Tanse, Veronica McKinney, Yaxenisikasan, Ninihia Wanisqueo. So good day, bonjour for those who are coming in from French areas. Thank you for coming and for being willing to hear about our talk today, for sure. I just wanted to do the basic disclosure, which is I basically don't have anything to disclose. And I also wanted to honor our ancestors. And I am coming to you today from the Treaty 6 territory and homeland of the Métis. That's my grandmother, my kokam and my musham on the left-hand side and my mom on the right-hand side. So I was very lucky that I got to grow up knowing a lot of my culture and traditional ways, which is actually not always the case for many people. And I acknowledge that many of you are coming from various territories across this land that we call Canada. And I invite you to reflect on the territories that you're coming from and the peoples that help to develop those territories, you know, that are part of those territories for wherever you're at, for sure. So just some quick facts about our Indigenous populations. So by definition, we're talking about First Nations peoples and Métis peoples and the Inuit. And even though we kind of label everybody under these 3 sort of major headings, the reality is there's a huge amount of diversity within these communities. And it's kind of like saying Europeans is the way to describe it, where there's lots of different countries, cultures, languages, accents, all kinds of things. And you'll see that even within our population here in Saskatchewan, we have 74 communities, for instance. But, you know, even if they're both Cree communities or both Dene communities, they could be right across the street from each other. And there will be differences in how things are said, languages, or how things are done on those communities. So I think it's really important to realize that it's just easy to say Indigenous, but the reality is we're encompassing a lot of diversity. And over the nation, about 5% of our total population are Indigenous peoples, which is the equivalent of about 1.6 million people. And so if you look at a map of North America, this just gives you an idea of where sort of the Indigenous populations are located. And of course, you see as you go further north, the more the populations increase. So here in Saskatchewan, about 16% of our total population are Indigenous people. So we have one of the higher population numbers. And if you look at the north where I work, and when I talk about the north, it's almost the northern half of the province here. We have about 40,000 people. And in this area, there's greater than 85% of the population is Indigenous. And that's actually higher than the Northwest Territories. It's higher than Nunavut or the Yukon for sure. And many of our people speak a language other than English as their first language. And 65% of the population are First Nations, and 50% live on First Nations territories. And that's important to note, because what that means is that when you are a First Nations individual, especially when you're living on First Nations territory, you fall under the federal system for healthcare, whereas there is also the provincial system. And we rarely talk about that there are two different systems, but that is one of the areas of gap for many of our communities for sure. The other thing to note is that many of our populations are quite a bit younger. So while the general Canadian population is lower in the younger populations and much larger in the in the older populations, so it's kind of the inverted pyramid. But in our communities, we actually have a much higher younger population and very small elderly population. So we are actually the complete opposite of the general Canadian population for sure. And we have what's called a higher dependency ratio. So what that kind of means is that those people that are sort of the pillars of the community, or the breadwinners, they look after everybody. It's like the classic sandwich generation, where they are looking after younger people and larger numbers of elderly people, and you know, kind of the very few of those people looking after larger amounts in general for sure. We have double the birth rate compared to the general population. And we have a lot of Indigenous people that live not only on reserve, but also in urban areas as well. So where I work is where I was showing you the northern half of the province, but I also work in the inner city here in Saskatoon. And the population that I serve there is greater than 80% Indigenous peoples. So we do see lots of distribution of various places of Indigenous people, both in the urban and in the rural and remote areas. And many people do tend to move to urban centers to try to find jobs, to try to access resources or medical services, for instance. Sometimes there's a lack of resources and jobs and things like that on First Nations communities, in fact, in most. And there's often poor access to healthcare, not only in the rural and remote areas, but when people come to these urban centers, often they find when they were looking for these access to resources, they're not always there either, and for a variety of different reasons. And so many of the inner core populations that we see in many of our communities across Canada definitely have a high Indigenous population. So what about COVID-19? What's really happened? So in Saskatchewan, you know, we sort of began to hear about COVID and did all the precautions that most had done. But the first actual outbreak that we had occurred in one of our northern communities. And it actually was related to those people in the community that had to go to work in Alberta, in northern Alberta, and there had been an outbreak there, which hadn't been identified yet. And so it brought the virus quickly to the small community. And how quickly it spread, I think, is an indication of how vulnerable our populations are, particularly in remote and rural communities, where there's a need to rely or to be around each other and to support one another. Many of the people that were infected lived in multi-generational homes. So one of the home members that I can think about, or one of the homes, had about 15 people in it, from as young as a young baby under 1, and an elderly people, 2 elderly people that were in their 60s as well. So the one person that ended up contracting the illness, right away, we were fairly soon able to identify that individual, and we were able to help with mitigating some of the ways of spread. But having said that, so I think the family itself did very well. Only 4 people in that entire household ended up testing positive for COVID. One of them, of which was the baby. But it did spread in the community very quickly, and this was prior to anybody knowing that they were positive for sure. What that did though, and I think the other thing that I would say too about our communities in the North is that very quickly, as they heard about this, they gathered themselves and organized in many ways, so that many communities came together, both First Nations and Métis and provincial, to look at what could they do to stop this virus from causing problems. We know historically, 100 years ago or so, when the Spanish flu outbreak occurred and the smallpox, 50 to 90% of our Indigenous populations were wiped out. And so many people recognized immediately that we would be at higher risk if we did get this virus into our communities. So I think while that was really positive that the communities would come together, the unfortunate part was that the burden, or the province, was sort of the organizers of what was going on within the provincial level, and spread that out to all sites, federal and provincial. So when there was this outbreak in the northern community, right away that became newsworthy, of course. And unfortunately, what it meant was that there were lockdowns that happened very quickly to the entire north, on the one side where this one community resides. And when this happened was right the day before checks were to come out for food and such. So unfortunately, many of the people had no food in their cupboards because they were waiting for their check day the next day, and they were going to get their food. And one of the issues in our northern communities is often it's difficult to get food. And so people often on their way up north, there's a large grocery store that's owned by one of our First Nations communities on the northwest side, where they stop and they get their groceries there. But the other problem that happened very quickly was that one of the people that worked at that store also contracted COVID. So before the checks were able to come out, and when the lockdown happened, that store had to close as well because of the positive person that they had there. So what that meant was people didn't have easy access to groceries. And because there was a lockdown, it meant they couldn't travel out. And again, this was early on, so there was a lot of confusion about why people could or should travel down south, what kind of things they needed to do that. And so there were fines initially that were handed out. And so some of the stories included, one of our community members had traveled down south to get groceries, both for his family, for his parents and the family, and for his in-laws and their family. But he was handed a $2,800 fine because he went down south, even though he explained that the reason that he went down was to get the food that they needed. So there were things like that were going on. The idea of lockdowns and not being able to leave your home was very difficult for many people. And it really did create a lot of uneasiness and unrest within the communities as well. And a lot of what was happening didn't seem to be implemented in a way that was equitable or fair. It seemed like the whole North was treated in a certain way. The other challenges that people had, I had a patient that I knew of that was coming down south for chemotherapy and had booked her hotel room, a few weeks before she was to come down. And when she came down to the hotel room, they actually turned her away because she came from this certain address that had been publicized in the paper. even though she herself had been tested, she had proof that she was negative. She didn't have any symptoms, and she had been very careful not to go around anybody, knowing that because she was receiving chemotherapy, that she would be at higher risk. So because she didn't have anywhere else to go, and she tried some other hotels, and they too were turning anybody from that community away. So she phoned some family and friends and found a cousin's nephew lived in another community, another further hour away. So she went and drove there and stayed on that cousin's nephew's couch for the night, then drove back an hour to get to the community where she was to get her chemotherapy, was able to get her chemotherapy, and then drove home. And I just think of how hard and how frustrating that would have been for that poor lady and for her family to have driven down to, you know, you're kind of steeling yourself against having to get the chemotherapy, knowing that, you know, you're probably not going to feel very well and such. And then being turned away and for no really good reason, and then trying to find a place to stay, and then having to drive further away and then further back again, and then driving home. It was, and there were many stories like this that were happening for sure. So many of our community people were not having particularly good experiences. And at that time, the hospitals were also, they're small community hospitals, but they were being told to, you know, be very cautious with allowing people in and only allowing them in if they were absolutely critically ill. So access to care, of course, was very limited at that time as well, too. Many common themes were the communities were able to mobilize fairly quickly. They wanted to protect their communities, and they were very concerned about vulnerability, both for the elders, kiteak as we call them in our communities, and also for the younger population, not sure what was going on. Initially, the younger population was not a high risk, and so that was a bit of a relief for a lot of people. But even within communities, they would have checkpoints so that they could provide information to people that were coming and going from the community, and making sure that people were able to take precautions, handing out things like hand sanitizer and masks and such, so that people did have what they needed to do to care for one another. Often, they weren't communicated with, the communities were not communicated directly with the decision makers around from the provincial level around how things would be implemented or what things were being done. And they weren't, many of our communities were not involved really in any way with decision making. And that was very disconcerting. But I also think it really meant that it eliminated the ability for those communities to really support the processes as best in the best way possible, and to have those processes be supported and trusted by their communities. Because when you're not part of those decision-making pieces, it's hard to trust what's happening. And oftentimes what was sort of put out as part of the processes really didn't apply to our communities, or wasn't done in a way that would have made sense for our communities. So it really, I felt, left our communities out in the cold in many ways, for sure. And it seemed, at least initially, many of the decision makers weren't really aware of why our population would be at risk and what were the issues that we needed to deal with in order to try to mitigate some of that risk, for sure. There were many trauma triggers. It was interesting. We had community meetings, and I was attending with those meetings to provide support, but also to provide information. And many people talked about feeling like they were returning back to the residential school type things, where they were being told what they could do, what they couldn't do, where they could go, where they couldn't go. In some cases, if they were sick, being, you know, taken out of their home and removed and put into a different place. Eventually what we developed, or what was developed in the communities, were having isolation units, so that if somebody was ill or tested positive with COVID, that they could stay away from the family, because so many of the homes there was so much overcrowding within the homes because there's such a limit on housing. The other thing to think about is that our homes are really not particularly great. When you are on First Nations territory, the rules around building doesn't seem to apply. And so things like, you know, insulation levels, ventilation levels, you know, all of those types of things. There's commonly mold in many of the homes. They're very thin. There's a lot of problems. And so when you have many people in an enclosed space that doesn't have a lot of great ventilation, as we well know now, viruses travel very quickly. So there were isolation units that were developed. But it's, you know, when you talk to people that had to go through some of that and spent time in those units, even though they had, you know, TV, it was kind of like a hotel room and people would bring them meals. It was very difficult for people, and the mental health piece was very challenging, not being able to, you know, be around people, especially when you're used to living with many people, not being able to go out into your community. You know, those things were big triggers for many people. There was a sense of government imposition, which has been well documented within our Indigenous communities, but it felt even more than usual, and racism that occurred as well. And so it was very triggering for many people in terms of traumas that they've previously experienced, but even in terms of traumas that they were currently experiencing as well. And so when that is happening, often mental health issues become a problem, and any medical conditions become worse, we know, when you're under stress and trauma, for sure. There was a lot of mistrust with the system for many people. And there was also a patchwork of services when we looked across the nation, because each province is responsible for their own areas and policies and things. What we were hearing from the federal side and what was being translated to in terms of the provinces were not always matching. And even between provinces, there were differences. And so many of our communities actually are along borders. And so it would be challenging to try to figure out, well, what am I supposed to be doing, and what are the rules, and who do I trust about this? Because it seemed like there was so much different information. And as a result of that, not unlike many people across the nation, there was a lot of confusion and mistrust about what to believe and what not to believe, for sure. Many gaps in services existed long before COVID came along. And in fact, Dr. Teresa Tam had stated this basically in one of her annual reports in October of 2020, and did identify that really some COVID and having the pandemic really highlights or shines a light on those gaps, on what some of the issues are and what we need to be trying, you know, that these will be widened during this time. And in fact, that's exactly what's happened. There were 3 areas that she talked about that we needed to really make it through the pandemic, and that we likely need to work on subsequent to the pandemic. And things like sustainability of leadership and government at all levels, not only from the top levels of provincial or federal, but even right down to the community level, and identifying who are the community leaders, who are those pillars, those individuals that are supporting the community members, and how do we best support them so that they can help be, you know, the knowledge keepers and the people that share the information for the community, and working within the community in an appropriate way. Having social cohesion would be critical. It's kind of ironic to me because it feels like there's more discord right now and not less cohesion, unfortunately. But having that cohesion is critical. And strengthen public health capacity would also be the other piece of things. So being able to have those resources that we need to ensure strong public health measures, for sure, would all be helpful. So, you know, it's interesting, this was a year ago now that this report came out, and I'm not sure that we've made much headway in any one of these 3 areas, to be honest. So what are some of the gaps that we've seen? Well, public policy often reflects what the general population is. And as I just identified, our population in the Indigenous communities is completely the opposite of the general Canadian population. I think this is really quite critical though, but so for instance, here in Saskatchewan, by 2045, our expectation is that our population will grow such that we will make up 1/3 of the total population. So it will have a big impact on what the needs are, where our resources need to be, and how we're going to address some of these differences in populations. We have high mortality rates, and that's from a variety of different medical conditions. And I usually tell people, if you just think of any medical condition, pretty much, we tend to experience it more commonly than the general population and have more of the complications and problems associated with those diseases. So everything from cardiovascular disease, chronic obstructive pulmonary disease, asthma, diabetes. There's just a variety of different things that we, you know, unfortunately our populations experience. And that's often a result of socioeconomic issues, but also issues in how the system was set up for our Indigenous peoples as a colonized system. And, you know, when we look at things like the burden of residential schools and the 60s scoop and kids in government care. So, you know, for instance, today we have over 80% of the kids who are in government care are Indigenous kids. And so those impacts that we saw from residential school are not gone. They are still being recreated to this very day, and things like adverse childhood events, which includes things like being taken away from your families, have long-term consequences and lead to things such as big impacts on healthcare, things like increased numbers of chronic disease, increased rates of cancer, increased rates of mental health issues, all kinds of different things. And we see that as a major public health issue for all children today, that we really do need to be addressing. Gaps in food security, as I identified, you know, really having very little access to food, fresh fruits and vegetables and things. To give you an idea, in the far north, if you were to buy a 4 liter of milk, it's about $12. The interesting thing is, and that's supplemented, it used to be much more, it used to be about $20 to $24. The government does supplement things like wine and alcohol, and that is much cheaper in many of our communities, as is pot, because pot companies supplement this as well. So when you look at being access to diet and keeping healthy, oftentimes the least healthy food is probably the cheapest and is what people have the greatest amount of access to. Housing, as I mentioned, is a big issue. Many of our communities, people actually have to sleep in shifts because there just simply aren't enough beds and enough places that people could go to sleep. And so, you know, your shift might be the night shift and somebody else's is the day shift. So when we think about people coming in to the hospital, for instance, sometimes they have to come in the middle of the night just because that's the time that they're awake. So we need to kind of work around some of those things as well. There are many safety issues in many of our communities. I tell the story about going out for a walk and being handed a crutch by one of the nurses. And when I asked what that was for, she said, well, that's for the polar bears. So we don't necessarily have polar bears in our north, but we have all kinds of different bears. And then in the inner city, there are gangs and things like that that are quite an issue. And even in some of our First Nations communities, I'm thinking more of some of the different ones, even in the north, gangs are also a big issue. So safety is a big issue for many of our people, for sure. We have high numbers of traumas and things like that, even being on the lakes and in the land. There's a lot of different things that can cause problems, for sure. There's few employment opportunities. Education is an issue. And often we've identified that when it's funded by the federal side, which is usually on reserve, it's usually about 30% less funding than what would be received on the provincial side. Poverty is experienced by many Indigenous peoples, and Indigenous peoples make up the majority of people in Canada living in poverty. Health access is a big issue. When you're living in rural or remote areas, it's very difficult to get in to see a doctor, and often you have to go out of the community to get access. And even to get transportation or such, you have to go through the federal side to get that. And I'll talk about that a little more. And like I said, just in general, that rural remote area. So travel, it's kind of a crazy thing. You know, an example would be where the patient needs to travel down south for maybe an ultrasound. And we've got situations where sometimes we can actually get somebody in right away the next day, but we can't actually get the transportation approved because they need more than 24 hours at the federal side to be able to get that travel arranged and accessed. So sometimes it's by road, sometimes it's by air. And we don't always have readily available planes available to come and get our patients, or teams that are assembled that can come and transport patients. Airstrips are a big issue, and being able to access via the lakes, whether they're frozen or whether they're thawed, and then in between stages. I've learned more as a doctor in charge of some of these things in the north that I never would have thought in a million years I'd need to know. But there are a lot of pieces to this puzzle to be able to get access to care. The other thing is even things like medical vans. Often the travel down can be several hours, and you're in this van with many different people. And often it's kind of a funny thing, but if you're on a First Nations territory and there's a nearby community and somebody needs to travel down south to the same place, but they're non-First Nations, out of that community, then they cannot travel on the same van. They actually have to go through different vans. So it's just kind of silliness around policies and rules that make it very challenging. And when you do travel to your appointment, you go to everybody's appointment in that van. So it's very challenging if you have diabetes, for instance, and you need to eat regularly and you need to eat healthy food. And the amount of money that you have for food is very limited. So it can make it very, very challenging for people, and it can be quite an exhausting day. At times, 20 hours is not an unusual thing that you would spend to go down for an appointment. So it can be very challenging. Childcare is an issue. We have many families that are large families or families with lots of young children. And unfortunately, when you're traveling to go to an appointment, you have to figure out ways to find childcare. And because the travel can be quite extensive, so sometimes even taking 3 days to go down. If you have to go down and stay overnight and then go for your appointment and then stay overnight and then come back the next day, that means 3 days worth of childcare for your kids, which can be very challenging for sure. Financial costs, because of course, a lot of things are not covered when you travel to go out of community for your medical care. And staffing, is the other big issue up north. We're chronically short-staffed. We often don't have adequate numbers of nurses. Many communities don't have high numbers of physicians, and those physicians are generally taking on many different roles, not just that they normally wouldn't be taking down south, for sure. During this time of COVID, we've also, I think, been a little bit more acutely aware of the racism. It's always been there, but I think things like, what happened with Joyce Echaquan in terms of the lack of care that she received and the identification that she died, at least in part, related to the racism that she experienced. And then, we've had examples from the past. Brian Sinclair, from Winnipeg, who also died, who came to the emergency department and waited for over 30 hours before he was seen. And when he was actually seen, or when his name came up, he had actually passed away already. And reports like First People second-class treatment in plain sight, done by Marion Turpel-Lafond. We've got lots of evidence that this racism within the healthcare system exists. It's systemic, it's built into these systems. We know that our current systems are based on colonized approaches. And so it makes sense that they don't actually work for everybody. And that in fact, there are many situations that, we just can't access healthcare in a good, healthy, sustainable way, or that's equitable to other peoples, for sure. We also during this time have seen the uncovering of graves of young children at residential schools that many of our communities knew about, but I think many people didn't really know, didn't believe, and now we certainly have seen a lot more evidence of that. But that has also been very triggering for many people as well too. And this is happening all across Canada, as most of you would have heard, I'm sure. So what have we seen with COVID-19? We certainly have increased morbidity and mortality rates related to the general population in terms of COVID. So I've experienced COVID being hit within my family. So I've had, my uncle, an uncle that's passed away. I've had cousins that have had COVID and now suffer from long haul effects. And what we've seen so far in our First Nations communities in Saskatchewan is that 2.6%, we have 2.6 times the rates of death in our Indigenous communities. And we have over 3 times the rates of COVID positive tests within our Indigenous communities. Just looking at the provincial side with my Indigenous patients and looking in the north, it looks markedly higher as well. We haven't been able to put the data together quite yet. We're working on that, but it is quite a bit higher. And this is a trend we see really across Canada as well. Manitoba's had several studies that they've done and have shown the same thing, and BC is not far behind as well. We're also seeing more nursing shortages and more healthcare provider shortages. A lot of times there were many people that decided to retire who had been working in northern communities or remote communities, many of our Indigenous communities. And then, so we had more new grads who didn't have as much experience. We had people who didn't have as much training, things like having nurse practitioners or advanced care nurses. when what that means is there's more of a reliance on physicians to provide support to help those nurses be able to do the job that they need. But we also didn't have many nurses working in those communities. So those new grads might be working short, and now, you know, they're feeling very stressed. So it also gave a negative taste, I think, for them to want to stay there, and many just plain old moved out. I think the other thing was there were more jobs available in urban centers around public health measures. And so many people chose not to go away from their families because they wanted to stay close during a pandemic. So for multiple reasons, there's less nurses in rural and remote areas, particularly in our Indigenous communities. And this is a national trend that we've seen for sure. There's been a lack of mental health services. And so for many reasons, the same reasons that the nurses were not able or weren't able to be sustained in the North, we're seeing the same thing with mental health services. And yet we're seeing a rise in mental health issues. Many of this is, again, related to isolation. Some of the one community that started with the first wave, for instance, in Northern Saskatchewan, has only recently had 0 COVID cases. So they've been dealing with COVID and lockdown issues, and, you know, trying to mitigate this terrible virus within their community for over a year. And it's been exhausting for many people, and it's been very challenging. And of course, the mental health issues that go along with that are quite strong. There have been, you know, many deaths in communities. And so that has also been very difficult, especially when you're talking about smaller communities and where we know each other and we're, you know, very often related to people. It's very difficult to deal with multiple deaths like that. There's also been the opioid crisis and addiction crisis that we're seeing, where there's been deaths that have been as much or if not more than those that we're seeing within COVID, and reduced access. And, you know, we talk about virtual care, but in our northern communities and in our communities here in the inner city, often what that means is actually phone calls. And so it's kind of a funny thing. It's been positive for some patients, but difficult for many. And many of our patients don't have phones. So this idea of providing care virtually, while it sounds very new age and great, it's just phone. and that's if it's working or if you have a phone. Even being able to book appointments now has relied a lot more on phones. And so we have some patients that have to go to their neighbor's house to use their phone, and then have to sit there and wait to be able to get through and to get an appointment, if they can even do that. So it can be very challenging for people to access care. There's been a worsening of the gaps, as we've identified, and reduced access for care outside of COVID-19. So many more patients coming in with far more advanced cancer, with chronic disease that is far more advanced and needing hospitalization. And that led to part of our ICU crisis here in Saskatchewan, along with our 4th wave of COVID most recently. There's been a lot of increased fear and mistrust, and many communities that have had great vaccine uptake and have had great results, more so than the general population, but also others with lower rates of uptake because of this fear and mistrust. Not so much anti-vaxxers, as has been portrayed maybe by our provincial premier, where they were sort of adamant against vaccination. It's more not really being sure about what they're hearing and wanting to hear from somebody that they trust. And when they can get that, and it makes a difference, and people are often more willing to take the vaccine with that as well. Communities that have come together, I think, has been one of the strengths that we've seen, where people are really working together to help one another and to share information from those that they trust, working around the inequities. So if they can't get things one way, they'll figure out other ways to make it happen or to do what they need to do. And I think the innovation that we've seen with that and how our communities really are pulling together has been amazing, actually. Identification of critical areas. So for example, with the racism piece, there's been a group of Indigenous physicians, a very small group, myself included, that come from community, work in community, and have been speaking directly with the federal government. And we advocated for change within the healthcare systems around teaching. So whether that's for nursing or for physicians, that there needs to be accountability. And we can't be talking about things like cultural safety until we identify what are the racism and the oppression things that are occurring. And we need to teach about that, because people don't really know about a lot of those pieces. So having some of those things and working on the policy end of things can also be quite positive, I think, for sure. I think the other strength that we've really seen is many of our communities have really have taken this time to be meaningful in terms of returning to spirituality and returning to cultural ways of approaching things, because that's been a strength for many people. But we've known that for a long time, that the more that people can build on their traditional lifestyle and culture, the more that they will be healthy. And we've got lots of proof of that. I think the other interesting thing is when you look at our petrograph teachings, which are the drawings that, you know, sometimes you see on rocks in different places around North America. One of those teachings is that they did talk about something coming along and causing a lot of illness and problems. But the other thing they talked about was that all the people, all the races, not just Indigenous peoples, have to come together. And when they do that, we will get through this. And so I think what that has done is many of our communities are thinking in that way, like, how do we work together to make things happen? And it's interesting timing when we talk about truth and reconciliation being about bringing people together. But the truth part also has to be there, as I've talked about with the finding of the graves and the traumas that have occurred and continue to occur to this day. Relationship building has been much stronger in some ways, even though we're further away from one another. We've learned innovative ways. And I think it's interesting that even many elders have learned how to use Zoom and FaceTime to be able to connect. And they want to be able to connect with one another, to be able to check in on everybody, make sure you're okay, but to be able to share their knowledge in ways that they have not used before. And I think that's been really amazing as well. And involving more of our Indigenous professionals in the decision-making processes, but also to be able to bring some of that or highlight some of the issues in communities that they're seeing and being able to identify ways of addressing that. And then also relying on information from trusted sources. So in some of our communities, as I mentioned, like our medical health officers locally will come and be part of the meetings sometimes, or, you know, maybe myself or family doctors from the community, people that they trust and that they can ask questions to, and we can have a conversation that is much more based on the relationship that we have along with our knowledge, because then that way they know that the information provided makes sense for the community and is trusted information. Building on strengths and capacities. The community peoples are often amazing people. I can often find that wherever I go, there's a lot of great knowledge and there's a lot of great talent. So we need to build on that a lot more. Using more things like peer models, peer support, and peer providers. The more we can build the capacity within the communities, the stronger it will be. And I noticed that on one of the summations from yesterday's meeting, this is part, I think, of what was being talked about as well. Working more closely with public health. What does that mean? And the fact that it is a specialty area. And when we talk public health, we're actually talking about what's in the best interest of the whole community, which is a bit different, I think, I think that's where some of the conflict happens, is individual versus community. But in many of our traditional or many of our Indigenous communities, we often talk about what's in the best interest of the entire community. And in fact, we have in our communities what's called teepee teachings, but one that's more prominently known as what the Haudenosaunee law, Great Law of Peace, which comes from the East. And one of the big tenets of that is that any decisions that are made have to be made in the betterment of all the community, not just for an individual. And it can't be made about an individual. It has to be for the betterment of the community. So I think some of these tenets we need to work on a little bit more and build on those strengths as well. People speaking out. We've had more people speaking out about what are the issues and what do we need to do about them, and how can we roll out, how can we get in there and help with a lot of these things, and advocating to make sure that those changes are happening and that these things are identified for sure. So some strengths as well have been some innovation. We've done some innovation prior to this whole pandemic, but it's really worked to our benefit. Things like some virtual presence type technology that we've used that is portable, we can move around where we need. And things like a remote presence ultrasound, which when we had our first outbreak, we weren't able to get people down south, as I explained. So we were able to do, for instance, prenatal ultrasounds using this remote presence technology, where the tech was down in Saskatoon, but we just were able to hold this sort of little device on the person's tummy, and we were able to do diagnostic ultrasounds, which was great. And it made a big difference for people to be able to get the care they needed in their own home, in their own town, where the people around them spoke their language and they felt comfortable with who was there. whoops, and kids have been disproportionately affected in the fourth wave. And we do have a lot of concerns in general about the upcoming season, winter season, especially with that close quarters and poor ventilation around other viruses, things like RSV for children and the flu bug, especially for our Kiteyak, our elders. And, just making sure that two of those things don't come together to really create further problems. Many things have been put on hold, like surgeries. We are something like over 30,000 surgeries behind here in Saskatchewan. It will take a year, I'm sure, just to begin to catch up. And there are those that will never get those surgeries and will suffer as a result. There's an increased in reduced access to care, I would say right now, versus improvement. And so we need to look at how can we change that, and a reduced number of providers as well. So we're going to need to figure out how we can recruit people and train people to be able to work in the north. And more importantly, how do we build within our own communities to be able to have some of that capacity? More increased focus on anti-racism and anti-oppression training, and accountabilities around that. And I think we're actually seeing that already, which is great. More recognition and more training being developed for sure. And the idea of need for cultural continuity, that the ability to look after oneself and be resilient resides in knowing who you are and being able to practice your ways of being. And as as Sharon said in my introduction, one of the things that people often think about is, well, maybe traditional means different herbs or different medications. But in fact, in our ways of being, it's everything from, how do you get up every morning? Do you say a prayer that gives thanks? Do you, what are the foods that you eat? Are you moving? Are you exercising? Are you being with your family? Are you connected with land, with your family, with your community? What are the ceremonies that you practice? So it's all encompassing, and it's so much more and so much more rich. And when we look at the climate change and things that are happening, we also see this as another trauma for many of our communities, in that the land is changing. Not only is it warming up, but things like forest fires. And then as we're seeing flooding and all kinds of things that are going on, that is also making it difficult for our community people for sure. And then restructuring must also include Indigenous ways of being, a meaningful engagement and decision-making with and from our communities. And that technology does have the potential to increase access to care, and that it can be quite positive. So in many cases, when we use some of this remote presence that I was talking about, what it meant was that the patient was talking directly with the specialist or with the doctor, and that the nurse or the doctor was on the sidelines listening in, and it changes the dynamic. Normally what would happen is the nurse or the doctor would talk on the phone and they would relay whatever the story was, and then they'd, it would kind of go back. And I liken it to talking through a translator, where you ask this question and there's this whole big discussion, and then the translator turns to you and says no, and you sort of wonder, what was that conversation? And the same thing happens commonly with our patients. And so unfortunately, that leads to distrust, because you wonder, was my story really told? What did they actually say? Did they really say what I was wanting them to say? So when you change that dynamic of having the person talk and being able to hear directly from this provider, it makes a big difference. It's not going to replace the face-to-face, but it can help in some of those instances where access is not available, and when it is difficult to get out of the community for sure. So I will stop there. I could talk on end with a large variety of things, but I will say and thank you. And we look forward to the question and answer session. Thank you.
Hi, thank you very much, Dr. McKinney. That was very, very well said. So people in the audience, if you have questions, please put them in the chat and we will go over those following the next speaker. So the next speaker, I'm pleased to introduce Marion Crowe, the Chief Executive Director of the First Nations Health Managers Association. Marion is an old friend and colleague of mine from years back when we worked at Health Canada. So I'm very pleased to see her now, and she's doing extremely well, and so proud to hear about her adventures and accomplishments. She's a proud member of the Paipot First Nation in Saskatchewan and was the founding executive director, now Chief Executive Officer of the First Nations Health Managers Association. Assisting community members in the development of professional development opportunities and certification has always been a passion for Marion, as she is a founding board member for Saskatchewan chapter of the AFOA Canada, which is the Aboriginal Finance Officers Association. And Marion has been awarded achievement milestones such as a Health Canada Deputy Minister's Award of Excellence, a Continental Leadership Award from the province of Saskatchewan, and a Xerox National Award Excellence in Aboriginal Leadership. Marion is a lifelong learner and currently is taking a course at the Harvard Business School, or actually completed a course entitled Leading People in Investing to Build Sustainable Community Certificate. On National Indigenous Peoples Day, June 21st, 2017, Marion was appointed as the first Indigenous person to the Ottawa Hospital Board of Governors. So I'm proud to introduce Marion Crowe. Thank you, Marion.
Well, thank you so much, Sharon. Tanse, everybody. And I am delighted to follow that presentation because it just beautifully set the stage for our story. And our story is that of the First Nations Health Managers Association. So let me tell you where you're seeing me from. It is a privilege to work, play, and thrive in the unceded, unsurrendered Algonquin territory of Ottawa. That is where the First Nations Health Managers Association resides, as well as the Mohawk community and territory of Akwesasne. So let's just dive right in. And I feel like I'm going to be giving you information. So I'm just going to warn you now, like it's going to be a fire hose of water coming at you. So I'll be quick and concise about what we're going to share, but we're just going to share the story of a national Indigenous organization and what it was for us to be working within this COVID-19 pandemic. So I will just kind of step back now and say that we are a national nonprofit organization. We are the organization that is preparing the workforce for the devolution, or as what I like to say, the evolution of health services delivery and having it shift from a government-focused control to our own control and our own destinies, where we can determine what we want to have as our future of health services. So I'm just going to dive right in. I don't have a PowerPoint. I like to just speak off the cuff, but if you're looking for this information, it comes from our annual report on www.fnhma.ca. All right, so let's step back, and I'm just mindful of time, so I'll take a look at my watch every once in a while. Let's step back now to March of 2020 when COVID was declared by the World Health Organization as a pandemic. So very quickly, like all of you, we had to establish remote workspaces for our whole family, our kin at the FNHMA offices. And really what our journey of COVID-19, because it impacted all of us, we're kin from all over Canada who work in Ottawa supporting our nations through health and wellness. So we're very, very quick to establish weekly COVID-19 specific health bulletins that were emailed to approximately 1,000 of FNHMA's subscribers. And it was just a matter of gathering. We really put into practice our hunt and gather history and looked for information that was particular to First Nation health services and COVID-19. But really what this meant too was establishing very quickly partnerships and counting on the partnerships that we already had as an organization to support the the information that needed to be reliable, credible, and factual. No more Dr. Google, no more Dr. Facebook. We didn't want any of that going on. We wanted to make sure we were sharing information that was from trusted sources. So that was very quick to happen again in March 2020. And we had a soft partnership with an organization called VIO Volunteers, who actually started an organization just to deliver PPE to Indigenous communities across Turtle Island. So March seems like it was, fire. It was just crazy for all of us. But not only did we do that in March of 2020, we also got together with Indigenous Services Canada, Dr. Valerie Gideon, and had a town hall to share information about the rapidly evolving pandemic 19 stats. In April of 2020, we made sure that we went back to Indigenous Services Canada and the Public Health Agency of Canada and 6 other partner organizations to send out public service announcements. And really, it was all about Thunderbird Partnership Foundation, Indigenous Physicians Association of Canada, First Peoples Wellness Circle, the National Collaborating Centre for Indigenous Health, the Canadian Indigenous Nurses Association, and First Nation Information Governance Center. Whew, that's a lot of partners. But what we wanted to say is we stand united behind our healthcare workers, behind custodians, everybody that was working tirelessly to keep our nation safe in those first couple of months. In May of 2020, we were very quick to launch InfoPoint. InfoPoint was an information sharing initiative developed by us. It was created to support those who have too much on their plate, and we know everyone was being just barraged with information, but we wanted to ensure that we had an actual call center established for an organization that knows nothing about call centers. I'm very proud to say our team set up a call center where we were dispatching COVID-19 information to everybody across Turtle Island. Didn't matter if you were Indigenous, non-Indigenous. We set that up and we did it in 15 days. I'll just let that sink in. A call center in 15 days. But my staff are the best. We have such a great family. So we did set that up where people could email us, they could pick up the phone, talk to a real person, and sometimes in an Indigenous language as well, so that we could share the information that was coming from public health, Indigenous services, and other trusted partners. We also started a daily environmental scan. So we were looking at all the top news stories, Indigenous Services Canada stats on what was happening in outbreaks like the doctor just described, especially in Northern Saskatchewan. I'm such a proud Treaty 4 territory band member from Pipot First Nation that it felt so good to be able to support Northern Saskatchewan at that time. We also went into news stories, all of the information in terms of disseminating to not just the Assembly of First Nations, but many provincial territorial organizations as well. And individual nations were accessing us to keep up to date on those daily stats. In May of 2020, we also started participating. First Nations were so quick to gather ourselves virtually and put together working groups that focused on the Assembly of First Nations leading a COVID-19 task force, the Indigenous Services Canada COVID-19 vaccine planning working group, the COVID-19 response and recovery working group, and of course, we started having the dialogues on anti-Indigenous racism in the healthcare system as well. And I'm so grateful that the stage was set so well by the speaker ahead of me. I'm sorry about that. My dad's calling me right now. You guys can appreciate working from home is like a next level. So we were really quick to, look at not just COVID-19, but trying to unpack the trauma that was happening with finding Joyce Echequan's recording while uncovering mass graves. And really, this was an epidemic within the pandemic. In August of 2020, we launched a pandemic planning tool as well for First Nations. This tool is still available to all First Nation communities free of charge to help and support communities with a personalized pandemic plan that would work within the context of how we deliver services on reserve. We were excited to have, included in that pandemic planning tool, essentials for developing a community pandemic plan that could complement what they already had in place. And really, it was about an ounce of prevention is worth a pound of cure. That's how we positioned that pandemic planning tool. During this time, we also quickly partnered with Indigenous media across Canada, and we launched weekly town halls on COVID-19 that aired, get this, on over 150 Indigenous radio stations across Canada. We were also playing on APTN every Saturday as well, and rebroadcast on hundreds of different social media platforms. The town halls, I will say, while it was a lot of work, we did 50 one-hour town halls over the last year and a half on top of our regular jobs, like all of you. It was a very busy time for us. But I want to give you a shout to point out, go to ihtoday.ca. Indigenous Health Today, ihtoday.ca. You can see those town halls and how the COVID-19 situation was evolving rapidly across Canada. I'll speak a little bit more to the content of those in just a moment. In terms of other activities that a national First Nation organization was able to undertake during all of this craziness is we are the organization that credentials and actually offers a certification for health directors on reserve. It's the First Nation Health Managers Professional Designation. And I want to say just a special shout out to Saskatchewan, because Saskatchewan is where our highest members of certified First Nation health managers are. But we do all of our training in person. We quickly had to throw that model out the window, and we launched a new hybrid education program during all of this too, that was adapted to all of the challenging times by reducing our intensive and online courses with a new and exciting hybrid course. And really what that was combining our real-time interactive sessions with groups who had the ability to work online without traveling or taking time off work. We also launched, we had 4 seasons of the town halls of COVID-19 information. And in November of 2020, I can't believe that was a year ago, but we did hold a FNHMA virtual celebration for healthcare workers and our graduating class, where we honored and recognized all of those fighting in our nations to keep us safe. So you can also check out that celebration. We had appearances from the Prime Minister, from all of the political parties, from our partners at Indigenous Services Canada, from Indigenous physicians, nurses, etc. But it was amazing. We also had music celebrities like Paul Brandt come and give thank yous to our healthcare workers. Paul Brandt used to be a nurse before he became a country megastar. So it was lovely to have him and a number of Indigenous artists like Buffy St. Marie also came and joined us to say a big hi to all of our healthcare workers. So we continued with the town hall right up until about a month ago, where we focused on Indigenous physicians giving information about vaccine confidence and trying to alleviate some of that vaccine hesitancy. So I do want to share a little bit. I know we're pressed for time, but I do want to say that in all of that, we had 20 live Facebook partners that would show our town halls. We had also 49 live episodes, plus the one with Indigenous physicians about a month ago. We also asked people to send us questions to the inbox. So anybody, Indigenous, non-Indigenous, and I got to say, I was surprised by the number of non-Indigenous viewers that we had on our town halls, because they felt like we were giving accurate, reliable, unbiased information. And it was so beautiful to hear non-Indigenous communities and people want to get their information from a First Nations source. How amazing is that? So we were building capacity within nations, but also within non-Indigenous community, sharing some of the challenges that we were facing at the time. So we had 450 questions come in that we fanned out to 120 different expert guests that we brought in. Folks like Carol Hopkins, Dr. Brenda Ristool, Dr. Valerie Gideon, Dr. Evan Adams. We just had such a wonderful array of people that stepped up to stand united with us in making sure that we were providing safe, credible, and reliable information. We unpacked some of those very concerns and issues that the doctor was just talking about now. And we had one question come in, and I'm just going to give you, this is a trigger warning, but it really, really just resonated with our viewers and with the speakers that we had on the town hall. One brave soul, and I thank this person, and I think we saved a life on this town hall. One person emailed in and said that they were a drug user, and that given that his nation at the time was exercising sovereignty and closed their borders to people from outside the nation. That meant, though, he wasn't able to get safe access to the drug that he was using. And he said he wanted to live. In that, we were able to intervene immediately with a mental health support, some cultural support. But these were the moments where we knew we were doing the right thing by offering the information from a trusted source, from an Indigenous person. It meant that we saved that person's life by offering the phone numbers to call, by offering just an ear, and for us to talk about it so openly. Oh, I still get really emotional when I think about that person who had that bravery and the courage. But that is some of the content that we were able to get to, is the increase in domestic violence that was happening, the unsafe drug supplies, people being broken by having mental health concerns, by caring for sick people. And all of this, we also saw a surge, a resurgence, I will say, of people coming back to our values, to our languages, to our traditions. I remember former National Chief Perry Bellegarde, Uncle Perry, I will say, talking about how we need to go and hibernate for a little bit. But during that hibernation, we can sow our regalia. We can start learning our language if it was lost. And we saw that resurgence happen over all of the waves of COVID-19 during this crazy pandemic. The other thing I want to share with you as well, briefly, is when we talked about the episodes and what we wanted to unpack within those episodes, we wanted to make sure that these were easy to follow. We weren't speaking in any kind of doctor or any kind of technical terms. It was layman terms, easy to understand, something my cookum, Marion Crowe, who has passed, would have been proud to have her namesake keep discussing so publicly, is information that was timely, credible, and reliable. Through all of that, our team was also, I'll come back to the moments where, you know, Cowessess First Nation, Saskatchewan's home for me. We were in a pandemic, facing an epidemic within that pandemic. And now our next battle is racism in the healthcare setting. There are national dialogues going on. I'm very proud to be a First Nation rep on the planning sessions for the national dialogues on anti-Indigenous racism. And I will part with this and direct you to two things. Rise against racism. Stand with us as allies. And if you see something, say something. As the very first Indigenous appointment to the Ottawa Hospital Board of Governors, I will make it my lifetime mission to ensure those without a voice have a voice. So rise with us against racism. And the other thing I want you to check out is the important work of Thunderbird Partnership Foundation and First Peoples Wellness Circle. We partnered with Nation Talk. Nation Talk is an Aboriginal newswire that you can subscribe to free of service. Just go to their website, subscribe. But the three organizations and FNHMA partnered together, and we launched Soar Above Stigma, a national campaign where we encourage you to share our Indigenous values of hope, resilience, acceptance, meaning, belonging, purpose. These are all around the stigma that was happening when people were when people were presenting with confirmed COVID-19. People were biased and saying, oh my goodness, they have COVID-19. We don't want to shame people. There's no blame, there's no shame. Those social determinants of health that were unpacked in the previous speaker about overcrowding, 15 people in one house, it was impossible to keep this out of our nations. But we want to be true to the resiliency. Hashtag Soar Above Stigma. If you dropped off groceries to your neighbor who may have been self-isolating, share it. If you are one of the people putting together care packs of PPE and distributing those to your nation and the households with cedar bundles, that was the marriage of inherent ways and Western practices wrapped up in a bundle, literally. Now that, my friends, is good medicine. So I do see that there are some questions coming into the conversation, and I'm going to pause there if that's okay, Sharon. And for everybody, thank you so much for allowing us time to sit and share a journey of the First Nations Health Managers Association. So back to you, Sharon.
Oh, thank you so much. Thank you. That was excellent. Okay, so now we're going to be moving over to the Q&As. So we have both Veronica McKinney and Marion Crowe here to answer any questions you have. So we do have a question in the chat, and that is, how can non-Indigenous patient groups support the leadership in Indigenous health to deal with the policies like separate medical vans that are utterly ridiculous, inefficient, and not value-based? So I'll leave that question for either of you.
Well, that's a good question. We've been working on it for a while. I mean, I think bottom line is, as the public becomes more aware that we have power, the public has a lot of power. So holding our politicians accountable, you know, I gave a quote from from our premier, which was completely inaccurate and very, prejudiced, basically. Well, our public really responded quite strongly. And I think there's a lot more power in our public in general than we know. And the more that we can have that cohesiveness, and I believe, again, that's that idea that Dr. Town talked about, let's get together. Let's really look at some of this and support one another to do the right things. And, I agree with Marion that there's many ways that we can have good medicine, but that coming together is powerful in ways that we can't even begin to think of.
Marion, do you have any comments to that?
Oh, I think the power of partnerships has been the true binding of Indigenous health supports. I look at some of the journeys we had in partnering, for example, with the Canadian Red Cross when Manitoba was being just decimated in the second wave. By partnering with the Canadian Red Cross as an Indigenous organization, we were able to deploy over 2 million masks into Winnipeg and have those sent out to some of the northern nations and communities. So reach out to your Indigenous organizations, to the communities, ask Indigenous patients. My goodness, we are a wealth of information on how we want to see policies improved, retuned, and where we can get to a place where we won't have biased information. And I will say, sitting on a hospital board, I carry the weight and responsibility of what that means, because it's not a token position if you don't let it be. Invite Indigenous leaders to your boards, to the boardrooms on presentations, and make sure that you get the education you need about Canada's history with Indigenous peoples.
Thank you. Thank you, Marion. Another question is, how can we build trust between nations which each of you have emphasized is so important to working together? Veronica?
I was going to say, since I started first, I could turn it over to Marion first, but that's okay. I think the number one beginning part I usually talk about is relationship. I think the bottom line is there needs to be an effort to find out not only the history, but find out about your community. Like I said, every one of us are in different territories. Whose territory are you in? Where are the people? What bands are nearby? Go and introduce yourself. It's not any different. I always say it's like when you go to somebody's house, you knock on the door and say, hey, hi, I'm here. I'd like to get to know you. Come on over for coffee. You start that relationship building and recognize that you are 50% of that relationship. So it's not just about kind of looking in as a, like a zoo where we look in on an animal and try to figure it all out. We got to figure out this animal, number one, first, which can be quite complicated. But recognizing that, and what, I think what I've learned in teaching students is a lot of times stereotypes and things are so ingrained in what's happening that people don't even recognize them for what they are. So really being open to learning to that. So I think relationship is critical. The idea that we're being respectful of other worldviews is also quite critical, to understand that there are different ways of approaching things. And the fact of the matter is, there's, like we always say, there's more than one way to skin a cat, there's different ways to get to this. And I think if you're open to that, then you also begin to understand and learn a lot more. The idea of reciprocity, it's not a one-way street, that we learn, we give, we take. So when, if somebody's coming or inviting you to come to their community for an event, take that opportunity and go. If you share what you have, it's a give and take. And that's, again, based on relationship. But then finally, also reflecting what feels right, what's working, what's not working, and really reflecting on what can you do better to make that relationship stronger and work. Like I often say, when you're in a marriage, in any relationship, it's work. So you have to constantly be doing that and thinking about those pieces. So I think if you start in I always make it that very simplistic way, but then apply that like one-on-one with a person or a patient or, an individual, a family, community, we can get to the nation. I think this is, if we could do those things, it'd be pretty amazing.
Oh, and I'll add on to that, Veronica, by saying it takes time as well. Trust takes time. We got to this place in history. This is where we are. This is the benchmark. Pick up the phone, start the dialogue, invite a presentation to your organization from your neighboring nation, from a First Nation health authority. Reach out to those provincial territorial organizations. They're so open, so welcoming to be able to sit at tables and have conversations, break bread together. Nothing will get people out more fast than serving food. Some tea and bannock goes a long way, but just be patient, kind to yourself, kind to them, and the relationship will come.
Oh, thank you. That's very excellent. We have another question here. How can we change the health system so it works for Indigenous people? Should we change the way we teach healthcare providers? And I think Veronica touched on that a little bit.
Yeah, I also do a fair amount of teaching as well. And, you know, obviously, yes, we do need to change the system, I think, in lots of ways. And, you know, the funny part is I really believe that if we change the system, it's going to be far more welcoming for everybody. You know, I think the linear thinking in the Western way is that you identify the problem, you deal with the problem, and then it's done. Life doesn't work that nice and neat, you know. And I think, you know, the more that we can incorporate some of these concepts, like we have great concepts from our Indigenous ways of being. Some things that I've done, for instance, is I've used sharing circles. So when I have a group of patients that has maybe diabetes, we have a sharing circle, and I incorporate both Indigenous and non-Indigenous people. And, you know, what's interesting is when we look at it from our perspectives, it's not so much the sugars or things like that that are the issue. It's our emotional responses to things. It's our lack of connection to other people or feeling very disconnected. And what's very interesting is the knowledge within the patient groups is huge, but we don't have a way of sharing that. So being able to incorporate some of those ideas are very good. You don't have to become Indigenous, and it's not all about ceremony. And I often tell people too, the other thing is that we have to be very careful not to misappropriate Indigenous culture per se. You know, many of my, you know, inner city people have never had that access to culture and training. So I'm careful when I'm teaching providers. It's not about becoming Indigenous or practicing our ceremonies. I don't have to become Jewish to be able to learn about Jewish people and to try to support what they need in order to access healthcare. It's the same thing, but being respectful, building relationship, like I said, all of those pieces are quite critical. And I think the idea of you know, healthcare in terms of really building capacity within community, there is a lot of knowledge that we just don't tap into. And I think the more that we can build upon that, the better it is. Using sound principles, you know, I think there's been a real issue lately with you know, with the media around all kinds of different information. We know that a lot of the misinformation for COVID, for instance, came from 11 people who ended up, this was money making for them. So I mean, we have to be, you know, let's base these things on solid principles. Let's come together at this as a coordinated way. But the reality is many times the information that patients have is huge. We really need to listen to that, to really learn and to really understand. But I think when we do those things, it's going to be better for everybody, regardless of whether you're Indigenous or not. So being able to find that place for as a patient, I want to feel comfortable when I come there. I want to see myself and feel like I'm being heard and respected. It seems basic, but you know, we've got a ways to go.
I love what you just said, Veronica. Thank you for saying that. I would add too that I would challenge everybody. It seems so simple, but please read reports like In Plain Sight. Read the Truth and Reconciliation calls to action, specifically 18 to 24. We do need to change the way we teach health providers Yes, there's a whole movement happening on ensuring that education is happening with those credentialing bodies of health professionals. Absolutely. But there's simple little practices we can do in our everyday lives. We can buy Indigenous, we can read Indigenous, we can watch Indigenous, but let's see an equal representation. And I was going to say brown faces in healthcare delivery. I realize I'm a very pale Indian. But it's about ensuring that we are amplifying access to Aboriginal health human resources. I will say that we are all concerned about the mass exit of healthcare workers within the system right now, especially when we look in provinces like Alberta right now. But think, if that's what's happening in the mainstream, we don't even have those health human resources to exit all of our institutions and all of our organizations. So I would ask of you, my new allies, please advocate with your MP, any of your city councillors. We need investments in Aboriginal health human resources, not just for mainstream healthcare delivery, but for our own building of capacity within our organizations, institutions, and nations. It's all about building the capacity so we can deliver our own services.
Okay, thank you, Marion and Veronica. So thank you so much for these fantastic presentations. I have one more question. Dr. McKenney had talked about gaps in public health policy that often reflect general populations, which is the exact opposite of Indigenous populations. Example, younger demographics. What are some ways that we can address this in public policies as we go forward?
Well, I think again, it's bringing that to the forefront. Like, number one, acknowledging we're talking completely different populations, and it means that we need to look at different areas for sure. And I think, you know, this idea of creating one template for an entire province or that type of thing, it doesn't work because we have such variation, and that's where I think we've seen COVID has really targeted populations within populations. So whether that's, you know, the Toronto Peel region, for instance, or Northern Saskatchewan, or these different areas where there are those differences, that's where we're going to see things kind of blowing up a bit. And I think what we also need to recognize is our populations are changing, they're dynamic. You know, we used to have this idea that we were sort of one big nation, but there's lots of different groups within the groups. And so I think having that nimbleness and that ability to pivot somewhat and recognize that there are differences. And this is where the patient-centeredness really needs to come in. And I think we're losing our way with that. We're talking, you know, here in Saskatchewan, we seem to have gotten in the idea of physician dyads. You know, it's funny coming from a physician, but a lot of physicians don't really know what they're talking about in terms of what the patient needs, because they haven't really had that opportunity. We need our patients there, and that needs to be patient-centered, family-centered. And yes, physicians need to have input and have some knowledge around these things. I don't mean to dismiss that. But the reality is those patients are the critical piece of this. And I think we're losing our way there. But the more we can get that direction, the more we're going to see those policies that reflect that. And those patient populations are different depending on where you go. And we have to acknowledge that and be able to pivot things so that it's not one template, but appropriate wherever you're at. And I think that's what we need to do.
Excellent. I'm glad you brought in the patient voice.
Yeah.
This one's kind of related to that one. What can people in the South do to support the people who live in rural and remote areas? It seems like all of the services are in the South, and people in rural and remote are kind of have more difficult access.
There's some amazing things going on, even here in Northern Saskatchewan. The Yukon is another place where there's a lot of work around community gardens and things where there's more teaching around how to do growing and such, depending on what the climate is like, but even using some new technology so that it could be year round. A friend of mine is from Fort Yukon, which is over on Alaska, just on the other side of the Yukon. And they've actually been able to grow bananas, if you can believe it or not, in these great big greenhouses that they've made and used. So, I mean, there are things that we could be doing. There's things like even the Good Food Box, where we have, you know, you can get a box of food, locally sourced food for $20. It varies just depending on what's going on and where they can get the food from. But and then they also have cooking classes and things like that, because, you know, my mom used to do a lot of parenting classes. And so for a lot of people, when they come down south, for instance, if you see a honeydew melon, if you're from up north, like you've never, like, what do you do with that? So, you know, we need to be able to show people what to do with these things. The other thing I will always strongly recommend too is that our traditional diets tend to be the low carb and the ketone diets. Those are the diets that were used to treat diabetes way back in the day. They are very healthy for our people. We don't really, and yet what do most people have that are living in poverty are high carbohydrates, which all switches to sugar. So a lot of the chronic disease that we're experiencing is related even to diet, and knowing that those things are so critical to being a healthy person. It's like I said, that was a large part of my teachings traditionally, was, well, how to eat the foods and what foods to eat at different times and things like that. And I think the reality is we need to get those food sources to be much more available. So supporting those local food resources. So if that's traditional meat or fish or things like that, when I was over in BC, our dietitians started learning from the elders how to harvest things like sea cucumbers and how to pick the berries and what we do with those and how to make this, how we stored them back in the day. And, you know, actually that was such better knowledge to spread with our communities and to support. And to be honest, it was so much healthier for our people. So the more we can try to support those types of things, community fridges, all of those different things that we have, I think the better it will be for everybody, for sure.
Okay, thank you. That's very good. Marion, I know you talked about the work that you do supporting people across Canada. What can people, like individuals, do from the South to support the people who live in rural and remote areas?
Oh, you know what? I think when we look at, here's a real big thing that was highlighted for me and many other First Nation organizations like the Assembly of First Nations. I think being champions and asking for infrastructure investments has been critical during the pandemic. When we talk about the technologies that Veronica was mentioning, you know, just we don't need satellite systems anymore. We need fiber in the ground to be able to reduce transportation costs, keep people aging at home safely in their homes, not having to leave the nation in which they're from. But I would love to see just investments. And we keep hearing about all of the investments that will be made by telecom companies. I used to manage e-health in Ontario and Saskatchewan for First Nations and Inuit Health Branch. And I'm telling you, the stats are still the same from when I was there 15 years ago. It blows my mind. Partner with the RCMP, partner with a health center, partner with a major provider in that area and get fiber, please. Let's get everybody connected so that we can have dialogues, we can provide services, and hopefully lower those food costs.
Excellent. Thank you very much. Well, thank you both for such wonderful presentations. We will be moving into breakout sessions at 2:20 Eastern Standard Time. So does anyone have anything to add before we close? Oh, just sorry, confused here. Sorry, we're moving on to our next speakers. So thank you very much for your presentations. And yeah, we'll be moving into the breakout sessions at 2:20. Sorry.
Thank
you,
everybody.
Thank you,
Yeah.
Sharon. Lovely to see you, Veronica. Bye,
Nice to
everyone.
meet you both as well.
Bye-bye. Ah, goodness. Okay, so, sorry, apologies. We're moving into our next speakers, which are the Kai session. So I'd like to introduce our next two speakers, Dana Reilly and Victoria Tenasco Kamanda. So Dana Reilly is a program lead with the Population Health, and Victoria Tenasco Kamanda is also an employee of Kai. So Dana has a PhD and has completed a postdoctoral fellowship in population health at the University of Ottawa. And in the work that Dana has done, equity is a key theme in all of her work. So during her time at Kai, Dana has made important contributions to a variety of products and reports, including Alcohol Harm in Canada, in the pursuit of health equity, defining stratifiers for measuring health inequality, as well as measuring health inequities, a toolkit. Dana is currently working on the development of racialized and Indigenous identity data standards for healthcare. I would also like to introduce Victoria Tenasco Kamanda. She's a program consultant, Indigenous Health, Canadian Institute for Health Information. Victoria Tenasco Kamanda is Algonquin Anishinaabe from Kitigan-Zibi, Anishinaabe in Quebec. She was born and raised in her community and spent much of her young life with her grandparents, Mary and William Kamanda. Moving to Ottawa to pursue a post-secondary education, Victoria has a Bachelor of Arts degree in Communications and Aboriginal Studies from the University of Ottawa and a Master of Arts degree in Canadian Studies from Carleton University. Victoria is currently pursuing her PhD in Education from the University of Ottawa, where her research examines Indigenous cultural safety and cultural revitalization in the context of maternal health. She actively pursues her equally important Algonquin and Anishinaabe education by learning about her Pimagawawin culture and Anishinaabemowin culture, which is language, whenever possible. Victoria is a program consultant with the Indigenous Health team at Kai, where she heads the work on Indigenous cultural safety and humility. Thank you. Dana and Victoria.
So welcome everyone. My name is Victoria. As Sharon mentioned, thank you for that nice intro, Sharon. So I just wanted to start off by welcoming you all to where I'm tuning into you from, traditional unceded Algonquin territory, which is where I was born, live, work, and play. Coming to you from Ottawa. And just wanted to share that because I know we're all virtual, but I also want to just acknowledge all of the lands that we tune in from, whether treaty lands, unceded, unsurrendered territories of all the Indigenous peoples across the country. So welcome to this presentation on race-based and Indigenous identity standards. So as Sharon mentioned, I'm the program consultant with the Indigenous Health team, focusing on increasing Kai-Hi's foundational capacity in the area of cultural safety and humility. And I'll just take a pause really quick to let Dana introduce herself as well. Sorry if I put you on the spot, Dana.
You did put me on the spot. Sorry, it's because I'm managing a couple of different things with the screen with the slides is over here and the video camera's over here. But anyway, hello everyone. My name is Dana and I will add a little bit of content after Victoria gives you some good details up front. So nice to be here.
Okay, good. I just wanted to give you an opportunity to show. Anyway, we're good. So next slide, please. So despite working on this project with Dana, who really leads this work, as the program consultant from the Indigenous Health team, I work very closely with Dana to ensure that the principles of cultural safety are respected throughout this work, and really play a role in, I guess, somewhat advising on the engagement part of this work, because it's really important at Kai that all of our work be Indigenous-led. in the best way that we can. So before we get to that part of the project, let me just give you sort of a brief overview of who we are. So CIHI is an independent, not-for-profit organization, and our mandate is to provide comparable and actionable information on Canada's health system and the health of Canadians. Our responsibility is to provide and publicly report on health data and information that improves outcomes in health system performance and population health across the country. CIHI's data standards make a positive impact on healthcare data and are used in each of CIHI's data holdings. Working with our stakeholders, we take a lead role in developing and implementing national standards to enhance the consistency and accuracy of Canadian healthcare information. So I think it's important to also mention that one of CIHI's priority population groups for both the 2016 to 2022 and upcoming 2022 to 2027 strategic plans is First Nation, Inuit, and Métis health. And it's important to note that although we will often use Indigenous and First Nation, Inuit, and Métis interchangeably, it's really important for us to make it known that at CIHI, the distinctions-based approach is the approach that we take. That's very important, which we've heard loud and clear from our partners. So although we will say Indigenous identity, just for record, the First Nation, Inuit, and Métis descriptors are important to reflect that that's the approach that we take in this work. Next slide, please. So just to give a bit of information about the types of data that we steward at CIHI, we steward nearly 30 different health databases from hospital to long-term care. A database is an organized collection of structured information, typically data. So when information about a patient is collected during a hospital visit, for example, these data are uploaded into one of our databases. We have a lot of data. We have 28 databases of comparable information on health services, the health workforce, and spending related to healthcare. We get these data from a wide variety of sources, such as hospitals, long-term care facilities, professional associations, provinces, and other organizations such as regional health authorities. And all of the databases that we get information from vary in size. So some of our largest receive on average 3.2 million records per month. So that's just to give you a little bit of insight into the kinds of information that we're talking about. So next slide, please. So we also thought it would be really important to give you insight into CIHI's Indigenous health strategy. So CIHI holds some databases that can identify whether a person is Indigenous or not. Self-identifying is not the only way for this type of data to be collected, but identifiers such as postal codes can identify this type of information as well. And because of Canada's colonial history, as well as examples of harm experienced by Indigenous communities through research or other, it's important to us to work with our partners to develop a strategy that ensures that data is collected and analyzed appropriately, that is culturally safe, that Indigenous peoples are in control of, and that risks of harm are mitigated. CIHI's Indigenous health strategy contains 4 pillars or priorities. However, although there may be 4 distinct areas of work, this work is also very interconnected and quite fluid. So if we look at these 4 pillars, some of the work that might fall under one pillar is also interconnected to another pillar, just by the nature of how relationships work between our organization and our Indigenous partners. And I think the relationships piece is quite important because that ensures that Indigenous peoples are in control of their own data, which includes what type of information can be analyzed and that we can support in an appropriate and respectful way. So again, going back to my comment earlier about how it's important for us to recognize and support Indigenous peoples, because we recognize that as a pan-Canadian health organization, we cannot and should not lead Indigenous health work. So if we look at the 4 pillars, we'll start with foundational capacity. So this is really about envisioning a Kai-Hai where cultural safety and humility are really hardwired at all levels of the organization. And the next one is relationships and partnerships. Again, really fundamental that relationships are at the core of our work. Kai-Hai can support but cannot lead this work. Or make decisions about Indigenous peoples without Indigenous peoples. Next, we have governance of Indigenous data. So we're really concerned with upholding Indigenous data sovereignty and aligning ourselves with Indigenous data sovereignty. And the last one there is analysis and capacity building. And this is really about sharing the knowledge so that what we do ultimately supports Indigenous peoples, communities, organizations in their priorities, so that, you know, our access or link to data to these communities ensures that this meets the unique needs that Indigenous peoples know that they need. Next slide, please. Okay. So Indigenous health guiding principles. So in addition to the 4 pillars, we also have a series of guiding principles that help guide our work. These principles help facilitate our Indigenous health strategy, and these are also very much connected to the pillars, and in fact, often come across as the same information to the pillars. But the guiding principles really ensure that if we're doing work in one of the pillar areas, that we ensure that the guiding principles help maintain like a wholesome approach to this work. So inherent rights to self-determination, including Indigenous data sovereignty, irrespective of where data is held. This really just means that, you know, we can have Indigenous identifiable data in the data that we steward, but it's not ours, and it's not ours to decide how it is being used. We just hold on to it in the safest, most culturally safe and appropriate way. So number 2, there is recognizing the distinct histories, interests, and needs and priorities. So again, going back to my comment about a distinctions-based approach, it's not enough to recognize that, you know, Indigenous peoples have a distinct history, interest, need, and priority. It's really about recognizing that First Nations, Inuit, and Métis people as distinct groups have distinct histories, interests, needs, and priorities. And so it's understanding that each of these 3 population groups has a different view and approach to data collection, data use, that kind of thing. Number 3, cultural safety and humility, meaningful and respectful engagement are essential. I think this is straightforward, just really understanding that all of the projects that we engage in have to be done in a culturally safe way, and Indigenous peoples must be engaged in meaningful and respectful ways that they really tell us how to do this. That ensures that Indigenous peoples are sort of like calling the shots in this work to ensure that it's meaningful and respectful. And the last one there is Indigenous-led partnerships and processes guide our work. Again, this is the recognition that although you know, standards and data collection and all of these data sort of connected processes are in our wheelhouse, but that we cannot make decisions about Indigenous health and anything connected to the data. So really recognizing that the work that we do, the partnerships, everything has to be led by Indigenous peoples, communities, organizations, governments, that kind of thing. Next slide, please. So finally, cultural safety. So if we look at the screen right now, we see a basic sort of definition of cultural safety. This is an outcome defined by the individual in which power imbalances are addressed and an environment exists that is free of racism and discrimination, and in which people feel safe. But I think it's important to note that cultural safety in our perspective is really both a means and an outcome. It's a means to the work that we do, and it is an outcome, again, defined by Indigenous peoples. And this is always going to be a fundamental part of any project or work that we engage in, because a safe environment, for if we're talking about this project in particular, a safe environment for data collection is critical. We know that Indigenous and racialized peoples is a very long history of mistrust within systems for Indigenous peoples. Cultural safety must be at the center of data collection discussions. We should really always be asking how is the data going to be used? Who owns the data? How does it benefit Indigenous and racialized peoples? And this is how cultural safety is a fundamental consideration for this work. It's not enough to engage in projects without thinking about the culturally safe aspects. So we can propose all of the standards that we could think of, but unless we also follow that work with information about how to do this safely, it's almost irrelevant. So on that note, I'll turn it over to Dana.
Great, thank you, Victoria. And before you turn off your video, just give me a thumbs up to confirm that you can hear and see me okay. Awesome.
Yes.
Wonderful. So thank you, Victoria, for sort of setting the stage for how we approach this work at CIHI. You, Dr. McKinney, and Marion are such tough acts to follow, but I'm going to do my best. Let's start with a few definitions. Equality means that each individual or group of people is given the same resources or opportunities. Health equity, on the other hand, which is a theme from from Monday's talk on addressing health inequities, is something that came up in some of those previous conversations. Health equity is really defined as the absence of unjust, avoidable differences in healthcare access, quality, or outcomes. And this on the slide is a great visual of the difference between equality and equity. And the difference is actually important in the context of the work we do here at CIHI. And we see that the people on the left all have the same size box, which in theory means that they should all be able to get their apple because they're all getting equal treatment. However, the people are all different sizes and some just can't reach the apple. Because of this, you might say there's an inequity at the apple farm. In order for us to change this, different size boxes have been provided to people depending on their need. This ensures that everyone can reach an apple, which brings equity. When we measure inequalities in healthcare, we often use sociodemographic data or the social determinants of health to understand and compare differences between groups. Things like age, sex, gender, income, education, Indigenous identity, and racialized groups are important measures for understanding differences between those groups. And if we can capture these sociodemographic data in a consistent way across the provinces and territories, then we can create pan-Canadian reports on different healthcare topics. So let's take a look at what this means at CIHI. Here are just some recent reports that have included really equity-focused measurement. So for example, in the report on hospital stays for harm caused by substance use in youth, the data showed that hospitalization rates were higher for youth living in lower income or rural and remote areas. In the report on alcohol harm, the data showed that males are more likely than females to be hospitalized due to alcohol harm, and people living in lower income neighborhoods are also more likely to be hospitalized. The point here is that standardized approaches to the measurement of the social determinants of health By having these standardized measures, we can incorporate equity stratification or data disaggregation into pan-Canadian analysis and reports. But in order to do this, however, we need to be collecting good quality data. And the first step to doing this is creating data standards that will harmonize data collection across the country. And that is why we released a discussion document on the proposed standards for race-based and Indigenous identity data collection back in July of 2020. Kaihai's work on understanding the importance of racialized group, ethnicity, and Indigenous identity, and the need to measure these concepts in healthcare has been ongoing for several years. But prioritizing implementation of these variables is direction we have received from senior leadership in various provinces and territories and at the federal level. So we have heard the longstanding calls for race-based and Indigenous identity data. They've really grown louder during the COVID-19 pandemic. That's because there's a strong need for disaggregated data to identify and address inequalities that may stem from bias, discrimination, and racism. By having pan-Canadian standards, we can help to ensure that high-quality data on a client's or patient's racialized group and/or their Indigenous identity could be collected and available for disaggregated analysis and reporting. We need to be able to measure it to monitor our progress and act on inequities stemming from racism and colonization. So in the report, we highlight some key learnings on the topic of race-based data. Race is a social construct used to categorize people based on perceived physical differences, things like skin color, facial features. There's no scientifically accepted evidence of a biological basis for the identification and classification of discrete racial groups. So race-based data is not about genetics. But being able to disaggregate health indicators by race can help to identify, monitor, and address inequalities and inequities that stem from bias and racism. Ethnicity, on the other hand, is a multidimensional concept referring to cultural group membership, and it may be connected to other factors such as language, religion, or nationality. Ethnicity data can be useful for tailoring culturally appropriate health services, particularly at the local level. Indigenous identity data are often collected alongside racial and ethnic categories during the actual data collection process. And although Indigenous populations experience racism and have their own unique cultures, they may not actually identify as racial or ethnic groups. As Victoria articulated earlier, at minimum, we know that the distinctions-based approach, that is, identifying First Nations, Inuit, Métis separately, is often preferred. And we've also learned from our work to date that Indigenous identity data and measurement should absolutely be determined and supported by Indigenous communities. And there's a need to respect Indigenous self-determination and data governance in this space to minimize those potential risks of harm. Kaihai's work focuses on pan-Canadian harmonization, but local engagement, customization, and data governance agreements are crucial. So I will now show you what the actual Indigenous identity and race-based standards for data collection look like. Like I mentioned, we're proposing a separate distinctions-based question on Indigenous identity to allow for flexibility in the way Indigenous people choose to self-identify. This is the proposed distinctions-based approach. And we are suggesting and encouraging people to think through how Indigenous identity data can be collected alongside race-based data through the proper engagement with communities in their local jurisdiction. This approach is aligned with other standards such as the census or the BC administrative data standards, and through a lot of the provincial COVID case report forms that are being used in various provinces and territories. This is the standard for race-based data collection. It's a self-reported, self-identified approach to measuring race, and respondents can select all categories that apply. Being able to select more than one category has come up as an important key feature of this type of data collection, because we know that a growing segment of the population here in Canada is in fact identifying as multiracial. So the question is, in our society, people are often described by their race or racial background. These are not based in science, but our race may influence the way we are treated by individuals and institutions, and this may in turn affect our health. Which category or categories best describe you? And the respondents are allowed to select all that apply. Since the release of that discussion document back in July of 2020, we've been engaging with a wide variety of partners, stakeholders, and community organizations to learn more about their perspectives. What we heard during all of this feedback is that there's overall agreement that race-based and Indigenous identity data should be collected in healthcare. It's not about whether we should collect this data, but rather how we can collect it in a way that minimizes the risks of harm and maximize the benefits for racialized groups. We've heard there are risks of harms associated with collecting race-based and Indigenous identity data, which may inhibit people from disclosing for fear and of discrimination in healthcare settings. So these risks should be identified and mitigated through processes that include community engagement, data governance, and safe collection of data, including the staff training. The purpose of the data collection needs to be clear, and respondents want to know how the data will be used. So there's a need for both transparency and accountability in the collection of race-based data. It's not merely just about adding these fields to data collection tools and forms and databases. There needs to be some actual planning for how this data will be used to improve the healthcare outcomes and experiences of racialized groups. We need to be ready to ask some tough and challenging questions, like, how is racism operating here? The implementation of these data standards will increase health system stakeholders' ability to monitor and compare differences in healthcare access, quality, experiences, and outcomes across racialized groups. As well, stakeholders can use the comparative data to inform anti-racism policies and programs aimed at improving health equity. But as patients, we can also hold the health system accountable to ensure that the race-based and Indigenous identity data is used to improve the care experienced by racialized groups, which can, in theory, lead to better health outcomes. So that covers the basis of our work, but we are more than happy to take questions on any of the information we've presented.
Thank you, Dana. We do have some questions in the chat room here. Let me see, I'll start at the bottom. Let's see. To what degree is qualitative data captured by CIHI? Asking with regards to collecting race-based data and data on the social determinants of health.
We do not have a very extensive qualitative data here at CIHI. Most of our data is in the form of quantitative data sets. However, we do use qualitative data to provide some of the important contextual information and really to dig deep in trying to understand what the data is showing us. But there's no sort of mass source of qualitative data collection happening.
Okay. Is there any intention to have a bigger, say, a qualitative section at CIHI?
Like I said, I do not think we're like formally sort of expanding qualitative data. It is more on like a case by case and analytical report or subject matter type of basis, where we seek out qualitative data to really dive in on a particular topic or issue. So it usually is more of like a case by case as opposed to a standardized approach across the organization.
Okay, thank you. And here's another question. To quote Dr. Kwame McKenzie, if you don't get counted, you don't count. On the other hand, we need to ensure that we don't use disaggregated data as a way of discriminating against those groups. You recognize this in your talk. How do we balance these two sides of the coin for the general public?
I can start, and Victoria, if you have more to add, please feel free to jump in, but absolutely. We do need to think about how we're going to integrate better sociodemographic data to get to be able to do that counting within the healthcare system. But like I said, there needs to be staff training, there needs to be community engagement, there needs to be data governance agreements in place to ensure that that data is collected in the right way for the right reasons. We've also heard from our engagement to date, there might be some different settings within the healthcare system that are more appropriate for this type of data collection to occur. So for example, in a situation where you have a relationship with a primary care provider, then it might be appropriate for this type of data to be collected. Being admitted to a hospital where you're just at a registration desk, it might be noisy, it might be loud, there might be other people, you have no relationship with the person asking you a question, that may not be the safest place to collect this type of data. So these are some of the things that we have to think through in terms of when it gets to the point of the actual implementation, think about how the data is going to be collected and in what setting to really minimize those risks of harm from this type of data being collected.
Okay, Victoria?
I mean, I think I would just add that I think like the easy answer is that to approach this kind of work using a cultural safety lens, and not like we can't really answer this question. I think this question would be better directed toward Indigenous partners, for example. So really carefully considering engaging Indigenous peoples to answer these questions, because again, like we have to think about how through the last couple hundred years, we have people in privileged positions of power making decisions about Indigenous peoples without Indigenous peoples at the table. So in order to ensure that this is done in the most respectful way that balances these two sides of the coin for the general public, it would be to include Indigenous peoples at the table to answer these questions. I think that's my personal perspective on that. That's the only thing I would add.
Okay, thank you. There's another follow-up question. There's a lot of talk about the importance of real-world evidence. Is CIHI engaged in those discussions so it will help CIHI collect these data?
I can start off on this one, Victoria. Absolutely, we are constantly in communication with some of our key partners about the real world evidence, better integration of data. You hear a lot about post-pandemic, we need to think about ways to build back better. And so thinking about how we can improve the timeliness, the availability, the accuracy of data is important. But just to clarify in the question, is that we at CIHI, in very few cases, we are not collecting the data. We are providing an opportunity for each jurisdiction, so each province and territory, to collect the data and then submit it, and we act as the data stewards. So we provide the opportunity for this data to be collected, and then we can integrate it into those pan-Canadian reports. But there's a lot of important considerations when you think about the different data flow that are worth considering, but certainly thinking about how we can bring in the data that we have available or make it easier for jurisdictions to collect this type of data is one of the things we're doing to get at more of that real world evidence. Victoria?
Yeah, I don't think I would add anything. I think you covered what I was going to say.
Okay, thank you. Here's another question. Does CIHI influence data collection that occurs across Canada? If so, what do they do to influence this data collection? Now, I can see this work on racialized data as one way, but can you elaborate a little bit on that?
Sure. So I think I might have given a little bit of this in my previous response, but we can set the standards for how this type of data is collected, but then it is up to each province and territory to really think through how they might actually collect it. So we can set those pan-Canadian standards, but it would end up being like a province by province, and then there's even variations within each province and territory about how and where this data would be collected. So we can give them the standard, and in some cases we can give them space should they decide to collect this type of data. We can give them the space to be able to report it into us. But the sort of, when it comes to specifically around race-based and Indigenous identity data, there's sort of guidelines, principles, key considerations for how this type of data is collected and used in a culturally safe way.
Yeah, and I would just add that we can set the standard, but we also can't tell people to use it. And we have to be respectful of the different ways that it might be used. So in this example, we're talking about Indigenous identity standard, racialized identity standards, and we can set that information up, but it can also be customized to meet the need of that particular area.
Okay, so thank you. So CIHI does work to influence by setting up these standards, right? So essentially, CIHI does influence. Anyways, that wasn't a question. Here's another question though. Tomorrow's agenda will focus on data to create a more resilient health system. Any key learnings on your process so far from some of the challenges you've experienced? And I know you've experienced challenges.
Yeah, I mean, we've definitely experienced challenges. It's not an easy project. It's not been fast or by any means, but it's a body of ongoing work. And I think, you know, if there's any silver linings from COVID or from the movements for racial justice that happened during COVID, is that we're sort of more ready to engage in a conversation about systemic racism and how systemic racism is a key driver in many of the inequalities and inequities that we see in healthcare access, quality, and outcomes. So, you know, this work is ongoing work, and it's work that's coming, and CIHI will continue to you know, engage on this topic, make this space available for jurisdictions who do their due diligence to be able to collect this type of data. And then, you know, if and when appropriate, think about how we can bring some pan-Canadian analysis, you know, that really sheds a light on the impact of systemic racism on healthcare access, quality, and outcomes. I mean, I think that would be the end goal, but it's not work that's, it's never going to, well, I hope that it's work that's not going to just stop with the release of the standards, because what we've heard and what we've learned is that this is a continuum, that you need to be engaging with communities, you need to be revisiting your the issues, you need to make sure it's relevant, and you need to find ways to make sure that at the end of the day, if the data is being collected, it absolutely must be used to improve the lives and the healthcare outcomes of racialized people. So it doesn't stop with the standard, right? Because it's very much a continuous process.
Mm-hmm. Good words. Victoria, you have anything to add for that? I think we have one more question.
I was just going to say that, you know, like we talk a lot about how Indigenous peoples are rightfully so reluctant to disclose identity just because of past encounters with the healthcare system. But I think it's also important to really, really highlight how, again, the silver linings of COVID, but some other things as well, that the calls for better data come also from Indigenous partners. So we know that this work is needed. And we know that this information is coming from Indigenous people. So even though there's a reluctance to disclose identity, there's also some really good work to come of this if the data is collected appropriately. That will only benefit Indigenous peoples, that will only benefit Indigenous health. So I just wanted to really highlight that, because, you know, we put so much emphasis on saying that this is Indigenous, work has to be Indigenous-led. And in many cases, like we just listen for these calls. And so like this work, despite that history, is only going to better the health outcomes.
Okay. I think we might have time just for another couple of quick questions, maybe. The first question is, are jurisdictions that collect this data receptive to this project and supportive of it? And then it says the more that are engaged, the better. And then the second one is, this is a great project. How can patient groups help to support it? So are they receptive, and how can patient groups support it?
Victoria, do you want to go first this time, or do you want me to have?
I think you could answer the first part of that question.
So the jurisdictions supportive of it, like, I think it varies across the provinces and territories. Some provinces are much more advanced in the process, because, like I said, and what I was trying to reiterate, we can make the space available for jurisdictions to collect this type of data, but just because we make it available doesn't mean they should add it to the form, because it's a process, right? It's a process of the community engagement, engaging with Indigenous partners, figuring out how they're going to be accountable for this type of data. So some provinces and territories are more far along on that, because it's a priority within their province or territory to begin with. So it depends on the location.
Okay, thank you. Okay,
Yeah,
and how could, sorry,
I was just going to say, and I think that second comment there that says the more that are engaged, the better. True, that is definitely true. But I think, again, we have to go back to that process, and whether or not a jurisdiction decides to include this information really there has to be an engagement process with local Indigenous folks to really determine if that's the best thing.
okay. And how can patient groups help to support it? Very quickly, we will be moving into group right now, pretty quick.
So I think that patient groups can help support this work by just becoming familiar with what we're doing and considering the benefits. And like I mentioned previously, we heard the calls loud and clear for better data, knowing who Indigenous peoples are and where they're accessing healthcare. I think all of the considerations that we brought forward are useful for patient groups to understand. And then to, I think it's just getting to know the work and to I don't know if you want to take over, Dana. I don't even know how to word this.
Support?
I think you've done great, Victoria. Perfect.
Yeah. Well, I'll end with that.
Okay. All right. Well, thank you very much for a fantastic presentation, the both of you. And we'll be moving now into the breakout sessions. So thank you, and we'll see you again.
Thank you, Sharon.
Thank you. Bye-bye. Now. Hi, Ron.
Hi. Are we together now in breakout? I was just plugging in a cord.
Sorry, and apparently can you guys hear me now?
Yes.
I've been
Yes, we
speaking to
can.
myself. Okay, great. All right. So I was just saying, we should be moved into breakouts automatically. This is for Axon to move us. In a moment, hopefully you will get a notice saying that you will be moved to breakout room number 1, 2, 3, 4, 5, 6, whatever it is. So hopefully that happens soon. And until then, I'll tap dance for you. You can't see the fancy footwork that is
There we go.
happening beneath me.
There
Here we go. You should all be getting a
Off we
notice now.
go.
See you on the other side, everyone.